As I said, we have selected 3 topics for this session, and the first one will be on high-risk disease. What is the definition of high-risk disease and what are the treatment options? As you can imagine, with such a complicated disease like multiple myeloma, there are several factors that may be qualified as high-risk disease or that contribute to high-risk disease, and generally we recognize disease-related factors and patient-related factors. So what I would like to ask the panel is what in fact is defining high-risk disease? What are the conditions that determine whether disease is high risk or not? And maybe I could start with Dr. Avet-Loiseau.
Okay, so most of the high-risk factors are disease-related factors, and we can separate them between cytogenetic or chromosomal abnormalities and then more related to the disease itself, like example, primary plasma cell leukemia. So to define the high-risk cytogenetics, I don't think we have to use conventional cytogenetics because it is only abnormal in maybe 10 to 20% of the patients, and it essentially reflects the proliferation. We have to perform a FISH analysis for all the patients. We have to be sure that your FISH lab is performing FISH on selected or recognized plasma cells. And I think that the 3 most important abnormalities we have to look for are the translocation 414, the deletion 17p, and the gain of 1q. And based on this, if one of these factors is positive, we do consider the patient with high risk. After that, for patients with plasma cell leukemia, definitely all of them are very high-risk patients, and we should have specific trials for these rare but very difficult patients.
Thank you. So we will show a summary slide of the cytogenetic abnormalities for the audience. Are there other disease-related factors that we would like to address today?
Probably, Dr. Avet-Loiseau mentioned already plasma cell leukemia, extramedullary myeloma, extramedullary disease is also a high-risk disease-related factor. And you may also look at the proportion of clonal to non-clonal plasma cells as a risk factor, which is disease-related. If you ask the question, which are the most important patient-related risk factors?
Yeah, we come back to that in a minute. Okay. So I put some things on the slide which may be considered as disease-related factors. Does the panel want to comment on this? Some of them have already been mentioned, like the cytogenetics, plasma cell leukemia. What about the others? Extramedullary disease and ISS stage? Dr. Cavo, would you like to comment?
Yes, I would like to mention also the adverse prognostic value of high LDH serum concentration, and also additional factors we can discuss for some of them if their value is that of a high or intermediate risk. Certainly the outcome of myeloma patients is driven by a high number of disease-specific factors, but I think that all of us agree that at this time the role of cytogenetic abnormalities is the major to be considered to identify a high-risk patient population.
So, and Dr. Einsele, what about ISS stage? Is that still regarded as important?
ISS stage 2 and especially 3 is still a high-risk feature, and from several studies we know that these patients do much worse than patients in ISS stage 1.
So then we come back to the cytogenetics. Maybe Dr. Aved, can you comment again? Is this the complete picture, or are we missing things?
No, I think it is almost the complete picture we know so far. So any abnormality detected by commercial karyotype, again, it is reflecting patients with high proliferation. We know it is a poor prognosis factor. The 414 translocation is important, and for these patients, the treatment of choice is probably bortezomib-based, VD, VMP. Deletion 17p, it's probably the worst chromosomal abnormality. These patients do very poorly whatever the treatment is. And now we have good data regarding the prognostic impact of deletion 1p and or gain of 1q. And so I think if we have to propose a minimum of probes, I would propose to look for translocation 414, 17p deletion, 1q gain. For deletion 1p, it's more difficult because we don't know yet what is the minimal deleted regions. For the other abnormalities, which are neutral or good prognosis, I don't think it is very useful to look for the 614, 1114, 5q amplification, hyperdiploidy, and deletion 13. At least in the IFM, we do not recommend to test these abnormalities since they don't have clear prognostic implications.
So FISH is still the current standard. I think we can all agree on that. Do you foresee developments for the near future that we are moving to other molecular tests, or?
Yeah, you are probably talking about gene expression profiling. Gene expression profiling, it's a wonderful tool, but I think it is still in the research setting, not in routine so far. And one of the problems with these techniques is that it is not feasible in at least 40% of the patients because of the quality of the sample. So we have to perform gene expression profiling in clinical trials, but I would not recommend to use it as a routine test.
Thank you. So with the cytogenetics still being on the screen, let's move to the patient-related factors. And Dr. Ludwig, would you like to summarize what's the importance of patient-related factors for the risk classification?
So one of the most important, if not the most important, patient-related factor implementing risk is, of course, age. So age is a definite risk factor. In addition, you may look at performance status, which is a risk factor. Excellent performance status is always associated with better outcome. And comorbidities are risk factors. And when you look at comorbidities in more detail, you should mention renal impairment. You should mention hematopoietic insufficiency, namely anemia, in particularly, but also thrombocytopenia. And neuropathy is also a problem because this limits you in your selection of treatments. So these are the most important patient-specific risk factors. And you may argue whether the ISS is also patient-related, and in fact it is patient-related because beta-2M increases with increasing age and albumin decreases in normal people. So there is a stage, if you use these staging systems, there is a stage migration with increasing age. So you will find more elderly patients with higher stage than younger patients because of these fundamental facts which are inherent in human beings.
So how do you handle this in daily practice? Is it just the doctor's eye, or do we have some other tools available?
I think this is important and will become more important in the future with more treatment options available. So we need to better tailor treatment to the individual needs of our patients. And I must say our tools are still rather rudimentary, and it depends more on the physician's experience at the time being. But in the future, I think I can foresee that we use more instruments which are validated for assessing the comorbidity status in our patients, the frailty status, in order to fine-tune our decision-making in those patients. But with that saying, age is certainly an important risk factor, and with age comes comorbidities, comes reduced performance status, comes increased frailty.
So we will discuss that later on. But what we have learned is that the population of patients is very heterogeneous in terms of the disease and of the patient-specific factors. So how do we consider these differences when we have to go to treatment? What do we want to achieve with the treatment, and what treatment options do we have? Maybe Dr. Kave wants to answer these questions or start a discussion.
Yes, the first goal is to achieve a complete response. Complete response is a surrogate marker of a prolonged progression-free survival and overall survival. The lowest level of complete response is immunofixation negative, eventually confirmed by lack of monoclonal bone marrow plasma cells and a normal serum free light chain ratio. However, we do recognize that there is a strict relationship between the deepest level of response and improved clinical outcomes. Therefore, in the novel agent era, a major goal is to achieve not only an immunofixation negative complete response, but hopefully immunophenotypic and molecular confirmed complete response. Another important issue, which is related to several subpopulations of high-risk patients, is to sustain a durable disease control and a durable duration of complete response. These patients do not have a lower chance to achieve CR, but have certainly a higher risk of early relapse or progression. Therefore, for several of these populations, particularly high-risk patients with high-risk cytogenetic profiles, a major goal is to achieve a durable complete response. How to achieve these goals? Certainly with the incorporation of novel agents as part of induction therapy, and the current therapeutic paradigm for these patients also includes consolidation and maintenance therapies. For several of these treatment phases, we have at this time the proof of a clear benefit which is derived from incorporation of novel agents. For other phases, we have suggestions, we have indications, but we need firm confirmation before conclusion can be drawn.
So, can you make any more specific recommendations for the use of novel agents for induction, for example, in a patient with high-risk disease, for example, a patient presenting with renal failure or other high-risk features?
Yes, I think that there are at least two high-risk subpopulations of patients who do certainly benefit from incorporation of bortezomib as part of induction therapy, and these are patients with T414 translocation and patients with renal failure. In patients with T414 translocation, especially transplant-eligible patients, we have data suggesting that bortezomib given as part of induction therapy and also eventually of post-transplant consolidation therapy is able to partially or completely overcome the poor prognosis which is related to these high-risk cytogenetic abnormalities. And another important issue is related to renal damage. In these patients, bortezomib can be given at full doses, and we have a lot of data suggesting that a fraction of these patients can recover a normal renal function, because recovery of normal renal function is strictly related to the speedy and the deepest of response, and both these goals can be achieved by incorporating bortezomib as part of induction therapy.
Yeah, thank you. So if you may summarize this part. So the goals is the achievement of a good response, a CR preferably, as you said, symptom relief, of course, and improvement of PFS and OS. And we preferably would use a free drug regimen to achieve this, especially in the transplant candidates. And also, I think this is always true, that we should find a careful balance between efficacy and tolerability in these patients also, and maybe especially if they are high risk. But then still we know that some patients maybe need an alternative strategy. Dr. Einsele, what are your ideas about patients that are very high risk, that we know have a high probability of relapse? Are there any other options?
What we know is that in spite of the novel agents we have available and use them specifically in the induction regimens, there is still a proportion of patients that has a very poor outcome even using these novel strategies. And we know that the overall survival of this patient cohort is below 2 years. So I think we definitely have to improve treatment strategies for these patients. And I see several options. One of them has been tested already in the IFM trial and also in the combined HOVON and GMMG trial, that is using maintenance treatment following stem cell transplantation. I think in both studies it has been shown that using lenalidomide and also bortezomib maintenance significantly prolongs progression-free survival also in the very high risk group of patients with multiple myeloma. I don't think the data are yet available for overall survival. Another strategy that we have been evaluating in the German multiple myeloma study group was to offer these high-risk patients an allogeneic stem cell transplantation, and especially in two patient cohorts, we have been able to show that allogeneic stem cell transplantation provided not only an improved progression-free but also an improved overall survival. And these were patients that were 13q deleted and also showed a 7dp deletion or had a 13q deletion plus high LDH, a patient cohort we know that has a very poor outcome. And obviously for this patient cohort, allogeneic stem cell transplantation could be an alternative strategy, and that is also being studied now in the European Myeloma Network studies.
So would you recommend to consider allogeneic transplant in first-line treatment or reserve it for a first relapse setting?
We offered it to our patients as a first-line treatment. I know that other groups are using the strategy for patients relapsing early after an autograft. So I think there are both options, and probably we need more studies to define the role of allogeneic stem cell transplantation in this ultra-high risk patient cohort. And I think both options, upfront or in relapse, could be an interesting approach.
Yeah, so we had long discussions on high-risk myeloma in this session, and then it always remains a question. We have active, novel strategies, novel drugs. We can apply them in the high-risk situation, but there is also the possibility maybe of using them in standard risk situation as well. So what in the end should we do? Should we give the best treatment only to the high-risk patients, or should we all patients give the best treatment? who would like to comment?
I think that we should offer the best treatment options to all patients, regardless of their inclusion into a low and high risk. And certainly the higher probability to improve significantly the clinical outcomes are for low risk patients. So at this time I do not suggest to tailor different treatment strategies according to the risk of the individual patients, and to offer a less intensive treatment approach to a low risk patients, and to reserve a risk patient, 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 and to reserve.
Dr. Einzelne?
I see two reasons to also offer standard risk patients the novel agents in the induction treatment. One is to really try to improve the best possible response. And we heard already that CR is associated with a prolonged progression and overall survival. And if we can cure patients with autologous stem cell transplantation, it will be the good risk patient group. So we have to offer them all we have to achieve a complete remission. And another, I think, important argument is that in the past, when we were using classical induction regimens like the VAD induction regimen, we had quite a significant therapy-related mortality, which is now using novel agents in induction treatment could be significantly reduced. And therefore, I think this is another very important reason to offer all patients novel agents for induction treatment.
So, Dr. Lafayette, so can patients be cured if they are standard risk and get all the treatment options?
I think all of us in the discussion agree that some patients are curable. And so probably these patients are more the low-risk patients. So definitely we have to propose them the most efficient chemotherapy, including novel drugs. However, even if some patients are curable, I don't think we are yet like in the Hodgkin disease, where we are decreasing the therapy intensity to try to decrease toxicity. We are not yet there in myeloma, so if we want to cure some of them, we have to give them the best treatment.
Thank you. Dr. Ludwig, you may give the final comments.
I think that has been very clear what my friends and colleagues have put forward. If you have insufficient therapy, you may lose some patients which you cannot rescue later on. So it's important to provide the best possible treatment to all patients. And I think the arguments have been raised. And these, the good risk patients are probably the best candidates for long-term remission and for cure. And we all are aware of that the patients with high-risk cytogenetic disease or high-risk gene profiles are still difficult to treat, and that is where the emphasis will be in the future.
With that, I would like to thank the panel for their comments and views on this issue. Thank you again.